Get ready to crack FMGE with PrepLadder's latest series. We've handpicked high-yield topics and prioritized questions from the recent Jan FMGE all the way till 2018. In each question, you'll have 5 seconds to answer before the correct answer is revealed. Don't worry if you get it wrong, Dr. Preeti will provide a brief explanation to break it down for you. So, let's jump straight into the first question. Question 1. A family pedigree chart is given below. Identify the mode of inheritance of this condition. Here are the options. A. Autosomal dominant. B. Autosomal recessive. C. X-linked recessive. D. X-linked dominant. And the correct answer is option A, autosomal dominant. Here's the explanation.
What do we mean by penetrance? Let us draw one family diagram and understand it. Okay, one entire family chart we will draw and we will understand it. So please remember, this over here is the grandfather. This over here is a grandfather and he has some diseased gene in his system. So basically, this is the grandfather and he has some diseased gene in his system. So there is a problematic gene defect that is present in his body, and because of that, he is showing signs and symptoms. Disease is also present. He has now given birth to, let's say he has given birth to a kid and that's a boy. So he has given birth to a boy, which means that that boy is also going to get the same gene. That boy is also going to get a same gene. And if he's got the same genetic problem, he will also show you the disease. This boy further had another kid, a further tiny little kid. Again, the gene has gone forward. You will say again, the gene defect has gone forward. So the defect is there. But suddenly, to your surprise and luck, the disease did not show up. What did you realize? That the gene has still gone forward, but the disease did not happen.
Question 2. Which of the following cells is responsible for destroying bacterial foreign bodies in liver sinusoids? Here are the options. A. Hepatocytes. B. Ito cells. C. Sinusoidal endothelial cells. D. Kupffer cells. And the correct answer is option D, Kupffer cells. Here's the explanation.
In the brain, please remember these are referred to as microglia. These are referred to as microglia. So glia will always remind you of glial, and glial means something to do with the brain, right? So in the brain, they are known as microglia. In the lungs have what? Lungs have a lot of carbon, pollution, dust. So macrophages are going to eat all of that dust. Macrophages are forever eating kind of cells. So they are known as dust cells. And because they are present in the alveoli, lungs mein kya hota hai? Lungs are going to have alveoli, right? So these are going to be the alveolar macrophages. What we are going to have is alveolar macrophages. Coming to the liver, which is a very famous question, that is the Kupffer cells. And if you believe that this question has become old in any way, or this is such a usual question that is never going to come, so remember the Jan 2023 paper of FMG had a question on this. So this question is not getting old anytime, and it has even come in very recent, the 2022 exam of INI CET, where it came as match the following. So this table is always going to be important, evergreen table. So remember, in liver, Kupffer cells.
Question 3. Which of the following is a sensitive and specific marker of intestinal inflammation? Here are the options. A. Procalcitonin. B. Fecal lactoferrin. C. Tissue transglutaminase IgA. D. High sensitivity C-reactive protein. And the correct answer is option B, fecal lactoferrin. Here's the explanation.
Inflammatory bowel disease or any other inflammation, whenever you want to know whether inflammation is going on in the intestine, what are the new markers? Because till now, they used to say C-reactive protein is a very good marker. But remember, fecal lactoferrin. Fecal lactoferrin is now coming across as a very good marker. For that matter, fecal calprotectin is also coming across as a very good marker. So these are the questions that have come in the recent 2023 FMG exams. You should be knowing calprotectin and lactoferrin.
Question 4. The X-ray of a middle-aged man showed multiple lytic lesions following which a urine examination was done. The sample revealed Bence-Jones proteins. Which is the most common immunoglobulin associated with this condition? Here are the options. A. IgA. B. IgD. C. IgG. D. IgM. And the correct answer is option C, IgG. Here's the explanation.
Multiple myeloma, V, C and M spike. M, please, M is not IgM antibody. M stands for monoclonal or myeloma spike. Monoclonal or myeloma spike, because again and again I'm telling you, the most common antibody is not IgM. The most common antibody is going to be IgG. That remains. So M is not for IgM. The antibody will still be IgG.
Question 5. Which among the following is not routinely screened before conducting a blood transfusion? Here are the options. A. Hepatitis A. B. Hepatitis B. C. Hepatitis C. D. HIV-1, HIV-2. And the correct answer is option A, hepatitis A. Here's the explanation.
What are TTIs? TTIs are transfusion transmitted infections. TTIs are transfusion transmitted infections, and these include, for India, remember, for India you have to test for 5 things, just 5 things, and that includes HIV, which is going to include both the HIV, testing for HIV 1 and 2, 2 hepatitis, hepatitis B, hepatitis C, malaria and syphilis. Repeating, HIV 1 and 2, hepatitis B and C, syphilis and malaria. These are the 5 testings which are mandatory. Not doing them is a legal offense. It is a crime. For not testing a donor and giving someone blood without testing for these 5 accounts for a medical legal case. It is negligence. So please remember, HIV 1 and 2, hepatitis B and C, malaria, syphilis.
Question 6. A patient who underwent surgery for a lipoma 5 weeks back now presents with a scar at the incision site that is limited to the original wound boundaries. What is the most likely diagnosis? Here are the options. A. Keloid. B. Exuberant granulation. C. Hypertrophic scar. D. Granulation tissue. And the correct answer is option C, hypertrophic scar. Here's the explanation.
So the picture that you have on the left is everything to do with the keloid, and the picture that you have over here is a hypertrophic scar. Okay, so now if I look at it, both of them are going to occur because of what? They are going to occur due to some kind of trauma, some kind of injury. So that is common to both, right? But I realize, like, let's say, for example, someone underwent an ear piercing. So many people you will see after ear piercing, they will come to you with this kind of a lesion, or many people are going to have this on the sternum also. So please remember, if they ask you, so for example, see, ear piercing. Ear piercing is 1 mm, one tiny little hole. So even if this female got a tiny little ear piercing here, but look at her keloid, look at her scar, it has gone much beyond, much bigger than the hole. So can I say this is something that is going to cross the wound margins? Keloid is something that is going to cross the wound margins, whereas look at a hypertrophic scar. Like for example, the surgeon gave an incision over here, there is more of scar, but along the line, it is not going here and there, left and right. So it is going to be within the wound margins. It is going to be within the wound margins.
Question 7. Which amongst the following molecules helps in the adhesion of the leucocyte to the endothelium during inflammation? Here are the options. A. P-selectin. B. Platelet activating factor. C. Selectins. D. Complement. And the correct answer is option C, selectins. Here's the explanation.
Now when I come to inflammation, did I not study at this point of time that all the plasma is going to flow out? Increased vascular permeability, the hallmark, all the plasma had gone out. So now there is no plasma that is present at the margin. All the plasma has gone out. So who is going to now take the replacement on the margin? The WBCs are going to come at the margin. So now that comes as the first cellular event. The first cellular event is margination. It is margination, which means that the cells are going to come to the margin. So that is why I am following the mnemonic MRAT-COP, because M is going to stand for margination. What is R? R is going to be for rolling. After coming to the margin, what are the cells going to do? The cells are going to, like a ball, The ball is rolling on the ground, so the cells are also going to start rolling. But now there's a twist which no one studies very carefully. So guys, listen to me very carefully. Can the ball keep on moving, or will you have to kick the ball? You'll have to kick a ball, push a ball, then only the ball will roll. Otherwise, it will just stop at one place, right? So what have you done over here? There is a force needed. Means once the cell rolls and comes over here, there is a few second attachment between the cells that happens. After that, again the cell rolls, it goes over here, and there's a few second attachment that is going to happen. So can I say this is just not rolling, this is rolling and weak adhesion that is going to occur. Just a weak. Why weak? Because for few seconds it is going to sit over there and then roll further. So it's rolling and weak adhesion, and you know who carries this out? This is carried out by molecules called selectins. Please note, selectins are referred to as CD62. We've not done too many CD markers up till now. Only one CD marker we did in the previous chapter of cell injury, which was CD95. Where did I teach you 95? It was a marker for apoptosis, right? Now I'm going to teach you CD62. CD62 is a selectins. And please remember, selectins are of three types. That is English, Premier, League. E-selectin, P-selectin, L-selectin. So first, what are we going to do? I'm going to make a very enlarged version of these two cells. Which two cells? The cell which is rolling. Which is the cell rolling? That's the WBC. The WBC is rolling. And on top of what is it rolling? The famous endothelial cell. So now I am going to make a very, very big image out of one WBC and one endothelial cell and have a look at it. So what have I done? I've made one huge WBC over here, and yes, this is a neutrophil. When you see these lots of lobes, those are neutrophils. Underneath, I have made a huge endothelial cell. So this is an endothelial cell. This is a leucocyte. You want to call it leucocyte, you want to call it white blood cell, anything, your choice. So one leucocyte, one endothelial cells, and I know that the CD62, that is the selectins, are going to be of three types, that is E, P, L, L. So can you tell me where will you see E-selectin? E-selectin, as the name tells you, E for E, that is, it is seen on the endothelial cells. This is where I will label E-selectin. Okay. What about P-selectin? How do you say P? If I start down to write P, P is sounding like P-E-E. So P-selectin is present on P for platelets and E for endothelial cells. So P-selectin is going to be present. Platelets are not drawn here. So endothelial cells also have the P-selectin. Where are the L-selectins present? L for L. L-selectins are present on the leukocyte. So this is where I will be drawing the L-selectin. So the question comes, which is the only selectin to be present on leukocytes? And that is obviously the L-selectins, only on leukocytes. So simple. When I say E, E for E, endothelial cells, P means platelet and endothelial cells, and L for L, that is going to be the leukocytes.
Question 8. What is the gene mutation seen in hemochromatosis? Here are the options. A. HFE. B. PTEN. C. ATP7B gene. D. MRP2 protein. And the correct answer is option A, HFE. Here's the explanation.
Can you tell me all the things in pathology, or even in, for that matter, micro or medicine, all the things that you study for chromosome number 6 that are important, even important in path, in medicine, and micro, everywhere. So first and foremost, the HLA gene that is present on chromosome 6. There is one more gene present on chromosome 6, and that is going to be the HFE gene. HFE gene is the gene for what? Fe. Think of iron overload. HFE gene is the gene for hemochromatosis. That is also present on chromosome 6.
Question 9. A 30-year-old female presenting with an unsteady gait, forgetfulness, labile moods, and Kayser-Fleischer rings was diagnosed with Wilson's disease. Which of the following options correctly indicate the gene mutated in this condition and its location? Here are the options. A. ATP7B gene on chromosome 13. B. ATP7A gene on chromosome 13. C. ATP7B gene on chromosome 17. D. ATP7A gene on chromosome 17. And the correct answer is option A, ATP7B gene on chromosome 13. Here's the explanation.
the Wilson's disease. The copper overload is referred to as Wilson's disease. So please remember, go back to your pasta, fried, chawal, mnemonic. This was also autosomal recessive. So hemochromatosis was also autosomal recessive. All the overloads are autosomal recessive. In fact, most of the things I'm reading today, alpha-1 antitrypsin deficiency was autosomal recessive. Hemochromatosis is autosomal recessive. Wilson's disease is autosomal recessive. All these liver disorders are more or less autosomal recessive. And what is the gene? Recent exam question. ATP7B gene mutation. ATP7B gene mutation is what is noted. You know why is this needed? Why do we need ATP7B? Copper doesn't travel alone in the body. So remember, to incorporate copper into ceruloplasmin, copper has to bind into ceruloplasmin for everything to remain normal. So basically, they two should be happy with each other, then everyone in my body will be happy. But if they do not get incorporated, if copper is not incorporated into ceruloplasmin, that is a situation where we talk about Wilson's disease. And why does that happen? ATP7B gene mutation. So obviously, now this copper will be going to different organs. It's a solo traveler. It's going to deposit in different organs. What all organs does it go to? The first one obviously has to be the liver, because that's the chapter that I'm reading. So what does it cause? It causes cirrhosis of the liver. Other than that, I can very well see it has gone into the eyes, and in the eyes it has resulted in a greenish brownish ring, and that is known as the Kayser-Fleischer ring. The question that you get in Kayser-Fleischer ring is, which part of the eye has this greenish brownish ring?
Question 10. A 30-year-old woman presents with a 1-month history of pain in the left knee, which is tender on palpation. X-ray shows a 5 cm mass in the distal femoral epiphysis, with soap bubble appearance. Microscopy is as seen below. What is the most likely diagnosis? Here are the options. A. Chondroblastoma. B. Osteoclastoma. C. Osteosarcoma. D. Osteochondroma. And the correct answer is option B. Osteoclastoma. Here's the explanation.
Which is the giant cell of the bone? Osteoclast. So can I call it an osteoclastoma? Can I refer to it as an osteoclastoma because it's an osteoclast? Yes. So here you have in front of you the giant cell tumor, which you correctly wanted to call as osteoclastoma. This usually occurs in a 20 to 40-year-old and in the epiphysis. Right now I told you it's an epiphyseal tumor. So do you know you have finished all the epiphyseal tumors? Let me tell you the mnemonic right now. Let's start working on our mnemonics also. So what are the epiphyseal tumors? For epiphyseal, your mnemonic is GCT. Means GCT, of course, giant cell tumor is epiphyseal. But other than that, we also have the C for chondroblastoma. Another giant cell one that I was telling you, chondroblastoma. And which variety of chondrosarcoma? Clear cell variant of chondrosarcoma. Clear cell variant of chondrosarcoma. So repeating once again, remember, or giant cell tumor, GCT mnemonic means it's for epiphyseal. These are all your epiphyseal tumors, right? And what is the location? Again, lower end of femur, upper end of tibia. So over here you've got a gross picture. Can you see this picture out here? It's very, very hemorrhagic. Put your little bit of common sense into it and you'll understand. Nothing to mug up. It is osteoclast. Osteoclast is the cell that breaks the bone. If the bone will be broken everywhere the bone is broken, of course there's going to be a lot of blood. So that is the reason there is so much of hemorrhage. And the same thing when you look at it radiologically, why is it looking all black? Because there's a lot of blood present. And this is known as the soap bubble appearance. This is known as the soap bubble appearance.
Question 11. Tau protein inclusions are involved in. Here are the options. A. Alzheimer's disease. B. Huntington disease. C. Amyotrophic lateral sclerosis. D. CNS lymphoma. And the correct answer is option A. Alzheimer's disease. Here's the explanation.
The neurofibrillary tangle. So get their name correct first. What is it? Neurofibrillary tangles. You know what is their other name? Because that will help you identify their picture. They are also referred to as flame cells. This means I'm now going to show you some cells which are on fire, which are carrying flame. But first I'll tell you what are they made up of. They are made up of hyperphosphorylated tau protein. Very, very, very important question. Let me show you. Have a look at this. Can you see there are some cells, it looks as if they caught fire? Yes. If you zoom into it, you will see that there are some lines in it. There are some lines in it actually. That is giving it that flaminess, that appearance of catching fire. Guys, this is the hyperphosphorylated tau protein. Same thing you can see on this stain. What stain is it? A quick repeat. What stain is it? It is the Biel-Schofsky stain. The Biel-Schofsky stain again. And what is giving it the flaming? What is the composition? Very important question. Hyperphosphorylated tau protein.
Question 12. The body of an 82-year-old man has been seen for post-mortem to know the cause of death. You are examining a histopathological slide containing a section of his cardiac tissue where you notice some pigmentation. Which is the substance that is seen in the image given below? Here are the options. A. Melanin. B. Lipofuscin. C. Hemosiderin. D. Iron. And the correct answer is option B. Lipofuscin. Here's the explanation.
So what is this lipofuscin or lipochrome? Remember, I call it the old age pigment. It is the old age pigment because you will always see a question as an 8, and I don't know what is their obsession, but they always give you an 83-year-old man. Why is it never changed into 85 or 90 or a 75? I don't know, but their favorite age is 83-year-old man. So this 83-year-old man will be given to you and he will have nothing, no major ailment he will have. But they will say there is a brown color pigment that is seen. So firstly, this is an old age pigment, so I call it senile atrophy. Second, it is a brown color pigment, so I call it brown atrophy. Why is it occurring in old age? Because in old age, we have a lot of free radical injury. What are free radicals? Everywhere around us. All the poisons and chemicals and air pollution and water pollution and every kind of pollution around us. What is it making in our body? It is making free radicals. So imagine if you have a 5-year-old kid and you have an 83-year-old man, who is going to have more free radicals? Obviously, the 83-year-old man is going to have more free radicals. So as the free radical injury will increase, the lipofuscin will also increase. So if I'm seeing lots and lots of lipofuscin, what will you analyze? This means this patient has had lots and lots of free radical injury, because I'll tell you the mechanism now. You know what free radicals do? Free radicals do lipid peroxidation. Free radicals do lipid peroxidation, and that is the reason that lipofuscin is formed. That is how lipofuscin is formed. Okay, so having said that, can I indirectly say that this is telling me a lot of wear and tear? Body is undergoing a lot of wear and tear. That is when it's forming. These are all its names. Lipofuscin, also known as lipochrome, occurs in old age, so senile atrophy. It is brown in color, so brown atrophy. It tells me about the free radical injury. It's a telltale sign, and it tells me about the wear and tear. Now let's look at it under the microscope. So I realize this blue color thing is obviously the nucleus of the cell, and something around the nucleus of the cell that I have is a brown color pigment. But that is exactly what I want to tell you. It's around the nucleus. The problem, or you can say the identifying point, is that this is perinuclear in location. That is how the question comes. You see an 83-year-old or an elderly man with a perinuclear pigment and you don't think of anything other than lipofuscin.
Question 13. Which of the following enzymes is responsible for the immortality of the cancer cells? Here are the options. A. Telomerase. B. Topoisomerase. C. Helicase. D. Anapolymerase. And the correct answer is option A. Telomerase. Here's the explanation.
So what exactly is a telomere? First, you will have to explain to me or understand with me what exactly is a telomere. So remember, if we draw a particular chromosome like this, TE for telomere, TE for terminal. This is where the telomeres are going to be. So telomeres are, like I said, TE. Telomeres are present at the terminal ends of a chromosome. They are present at terminal ends of a chromosome. Okay, so you know, when we are born, at birth, we have thousands of telomeres at all the ends. At all the ends, we have thousands of telomeres. You know what is the sequence of one telomere? One telomere is going to have a sequence of TTA triple G. TTA triple G is one telomere. Like this, we have multiple thousands of telomeres. But as we will have cell division, with each cell division, the telomeres will become short. The telomere is going to become short, and that is the reason that we are aging. So just giving you an example, at birth, there's a child, there's a tiny little kid at birth, he has 1000 telomeres, just a random number, okay, 1000 telomere. So please remember that as he will age, he will divide, his cells will divide once, twice, thrice, 100 times. So you will realize that every time the cells are dividing, from 1000, the telomeres are becoming 900. Next division, 700. Next division, 500. Next division, 200. So with every division, the telomeres are becoming shorter and shorter and shorter. That basically means that the telomeres will ultimately finish one day, and that is when we will say this person has become old. So like I said, what is the cause of aging? In front of you, one of the causes of aging is the telomeres becoming short. So there is a diagrammatic representation that you can very well see over here. As you can see, this is a chromosome in front of you. You can see what the terminal part has. You have TE terminal, TE telomeres, and you can see that as the cells are dividing. So see, initially you had so many telomeres. Once the cell divided, the white area, the telomeres are becoming smaller. Then the cell divides, the telomeres are further becoming smaller. Then the cell divides, and look at now, it's become white. The telomeres have vanished. That is when we say the person is becoming old. So is there anyone who can stop this? Of course there is someone who can stop this, and that is an enzyme called telomerase. So please remember, a telomerase, it's actually an enzyme. It's a kind of a polymerase enzyme. It is an RNA dependent DNA polymerase. It's an RNA dependent DNA polymerase. So what is it going to do? It will prevent, it will say, okay, if you have 1000 telomeres, I will keep it at 1000. I will not let anyone, you will divide, but your telomeres will not go short. So please remember, it prevents telomere shortening. It prevents telomere shortening. It says, never mind, you divide, I will not let your telomeres shorten. So tell me, by chance, although that doesn't happen, but by chance someone is having too much of telomerase in the body, will that person's telomere ever shorten? Not happening. If that person has 1000 telomeres, he will end up having 1000 only by the end of it. So will that person ever age? If someone's telomeres are not shortening, that person will never age. So can I say telomerase is also referred to as making someone immortal? Telomerase is very famously known as the immortality gene. It is very famously known as the immortality gene. I'll repeat that. Why? Because whenever someone has telomerase, his telomeres will not shorten. If the telomeres will not shorten, that person will not age. That person becomes Amar. He becomes immortal.
Question 14. A 65-year-old man was admitted to the emergency ward with severe, sudden onset chest pain radiating to the left arm and profuse sweating. ECG showed ST segment elevation in precordial leads. The person succumbed after 3 hours. During the autopsy, his heart was taken out and immersed in a solution. The normal area of the heart turned brick red, whereas the infarct portion turned white. Which of the following can be the likely component of the solution? Here are the options. A. Formalin. B. Triphenyl tetrazolium chloride. C. Ethanol. D. Glutaldehyde. And the correct answer is option B. Triphenyl tetrazolium chloride. Here's the explanation.
Please remember, I will use a stain called TPTC. What is TPTC? Triphenyl tetrazolium chloride. Triphenyl tetrazolium chloride, 4 letters. So this is useful up till how many hours? When the person has died within 4 hours. Because within 4 hours, I can't see anything with my 2 eyes. So just for example, if this is the heart, you're trying to look at it with your own 2 eyes, you're not seeing anything. So what will you do? You will paint it with which dye? You will paint it with TPTC. Because the principle is that TPTC stains LDH1. TPTC stains LDH1. And does a normal heart have a lot of LDH1? That is what I've been telling you. The normal heart has LDH1 present in it. So what is the color that it's going to give? It's going to give a nice brick red color because LDH1 is there, so the color will come. And here I can see a beautiful brick red color because everything in this heart is normal. However, if you're talking about a heart which has undergone myocardial infarction, is there going to be LDH1 in a dead heart? No, it has all released all the LDH1. Now are you going to get a brick red color? You will not. Now the color that you will get will be a pale off-white color, and that is exactly what you're seeing in this area. So what happened when I got this heart in front of me, I painted it with TPTC. I saw that everything was brick red, but that one area was a little white, little pale. I said, okay, this is the area where the myocardial infarction has occurred. So remember, TPTC.
Question 15. A patient presented with a midline swelling in the neck and weight loss. The consulting physician decided to go in for a thyroid biopsy. Biopsy revealed the presence of Orphan Annie eye nuclei. Which of the following is the likely diagnosis? Here are the options. A. Follicular thyroid carcinoma. B. Papillary thyroid carcinoma. C. Anaplastic thyroid carcinoma. D. Medullary thyroid carcinoma. And the correct answer is option B. Papillary thyroid carcinoma. Here's the explanation.
When we are dealing with the cancers, we have papillary, follicular, medullary, anaplastic. Which is the best prognosis? The best prognosis is papillary. Which is the worst prognosis? That is going to be bad anaplastic. This is going to be a patient will come to you with rapid enlargement and there's going to be deterioration. The thyroid will rapidly enlarge and there's going to be very severe deterioration and the person will deteriorate very quickly. So that is why it's said to have a very bad prognosis. What is it about papillary? So remember, for papillary, it's associated with radiation, with Hashimoto's, with thyroglossal cyst. What is the most common mutation? The most common is BRAF. Other than that, red PTC is also seen, others are also seen, but BRAF is most common. What are the findings that you notice? The first finding in front of you, this is the very famous Orphan Annie eye nucleus. Yes. What do you see over here? I can see an inclusion, intranuclear inclusion. And what do I see over here? The coffee bean appearance coming to a body. What is this body? The very famous Samoma body is also noted. And finally, what is the finding that I see on an FNAC? On FNAC, I see the very famous chewing gum colloid. So chewing gum colloid is also something that we notice on FNAC. I hope that is okay with everyone. You're able to visualize the entire spectrum of papillary.
Question 16. Which antibody is present in celiac disease? Here are the options. A. Anti-tissue transglutaminase A flat. B. Anti-endomysial A flat. C. Anti-gliadin antibody A. D. All above. And the correct answer is option D, all above. Here's the explanation.
Now I can finally tell you that in this process, what all antibodies were formed. Anti-tissue transglutaminase antibodies, anti-gliadin antibodies, and anti-endomysial antibodies.
Question 17. Liquefactive necrosis is seen in. Here are the options. A. Heart. B. Brain. C. Lungs. D. Kidney. And the correct answer is option B. Brain. Here's the explanation.
Liquefactive. Now, did you notice when I was teaching you coagulative necrosis, I said all the solid organs, but I did not mention the brain and I did not mention the pancreas, because finally these two solid organs show you liquefactive necrosis. So what is the meaning? If I talk about liquefactive, something is going to become liquefied, right? So now when solid organ like brain is becoming liquid, can I basically say that the tissue architecture, look at this area, it's becoming a little liquidy. So do you think the tissue architecture is preserved? Not at all. So please remember that this is the difference between coagulative and liquefactive. The tissue architecture is not preserved. The tissue architecture is not going to be preserved. So let's take some examples. For example, you have like CNS, or I'm saying brain. For example, you have something to do with a stroke. So this is what is going to happen in the brain. For example, you have a case of pancreatitis. This is what is going to happen in the brain. So any reason Or a pancreatitis obviously going to happen in the pancreas. So any reason, guys, that why only brain and pancreas I'm considering over here? Because these are the enzymes which are very, very rich in enzymes. So these are very rich in hydrolytic enzymes. And that means that whenever enzymatic activity will be more, the area is going to become liquefied.
Question 18. Most sensitive indicator for iron deficiency anemia? Here are the options. A. Serum ferritin. B. TIBC. C. Percentage saturation of transferrin. D. Bone marrow iron. And the correct answer is option A. Serum ferritin. Here's the explanation.
Because the word tells me that for giving the diagnosis of iron deficiency, I cannot do that without analyzing iron studies. Okay. So what are the different iron studies that you have to know about? Listen to me. First, you measure serum iron. You measure serum iron, measuring the levels. Next, you measure what does iron bind to? Iron binds to transferrin. So next, what you measure is transferrin saturation. What we measure next is transferrin saturation. What is the storage form of iron? Storage form of iron is ferritin. Okay. Now, there's another parameter which you call as TIBC. Please note the full form first. Total iron binding capacity. Total iron binding capacity. Okay. Right now, these are your basic things. Then I'll tell you some advanced ones also. Basic में क्या आता है? Iron, transferrin saturation, storage that is ferritin and TIBC. Think logically. You are dealing with a case of iron deficiency anemia. Do you think iron levels will be normal, lower, increased? Of course, iron deficient है तो ma'am, iron deficiency में iron levels will be low. If there is less of iron, no one will bind to transferrin. Transferrin saturation will also be low. If there is no iron, then bank account may be no savings. Nothing is going to be there. Full, poor, broke person. No iron, no saturation, no ferritin, no transport, no storage, nothing. Now, when you have no food in your system, and even if I give you one piece of chocolate or one toffee, you are going to like grab onto it and eat it. When you have no iron in your system, what do you think is your hunger? Total iron binding capacity. You will say, ma'am, my hunger is 100%. So the only thing that has increased is TIBC, the total iron binding capacity.
Question 19. Most characteristic finding of diabetic nephropathy? Here are the options. A. Kimmelstein-Wilson disease. B. Diffuse glomerulosclerosis. C. Focal segmental glomerulosclerosis. D. Armani-Epstein change. And the correct answer is option A. Kimmelstein-Wilson disease. Here's the explanation.
Have a look at this. This is what you call as NGS, nodular glomerulosclerosis, which means that there will be a picture of a glomerulus which I can very well visualize over here, and there is going to be some nodularity that I will notice. Nodularity of what? Sclerosis. Sclerosis is pink material. So I can very well visualize there is pink color material here, there is pink color here, pink color here, pink color here. There are multiple pink color lesions that are basically going to be present in a case of nodular glomerulosclerosis, and this is also known as the Kimmelstein-Wilson lesion. This is also referred to as the Kimmelstein-Wilson lesion. And why am I spending so much of time on it? Two questions. Firstly, what is that pink nodule formation? So what is that? These are all non-enzymatic glycosylated products. These are all non-enzymatic glycosylated end products, which you know is one of the major findings that happens in diabetes. In diabetes, there is glycosylation, right? There's a non-enzymatic glycosylation. So these are all the products. Question number 2, this is the most characteristic lesion of diabetes mellitus in the kidney. This is the most characteristic out of all the full mnemonic that I taught you. And question number 3, this is pass positive, which they shall ask you in the form of an MCQ. They will show you this lesion, they'll give you a history of diabetes, and they will ask you what is the stain that you should be putting. So you should be putting that pink color stain, which is known as pass.
Question 20. Most sensitive and specific marker for myocardial infarction is? Here are the options. A. Troponin. B. Cytokeratin. C. myoglobin, D. CPKMM. And the correct answer is option A, troponin. Here's the explanation.
I prefer troponin T, troponin I. Out of troponin T and I, which one do I prefer? Always remember the one that looks like I. So finally we can say troponin I is what is the most important. Which is the most important? I for I. Troponin I is going to be the most important. Coming all the way back. So now you need to know that when do they rise. So when you take troponin and you take the next one, that is CKMB, you will realize both of them are rising somewhere equally, 2 to 4 hours. But when are they going to fall is different. See, CKMB, which is a chota naam, smaller name, CKMB. How many alphabets? 4 alphabets. So have you seen in less than 4 days it has fallen off? What is 48 to 72 hours? 2 to 3 days. Na? So basically less than 4 days it has fallen off. Easy to learn. CKMB. Within 2 to 4 hours it increases, starts, and within 2 to 4 days it's out. That's it. CKMB. Everything with 2 to 4. On the other hand, troponin also started within 2 to 4 hours, but troponin, the lengthy name, troponin is such a long name, troponin T, troponin I, troponin goes for 10, troponin 10. So troponin is going to fall after 10 days or at around 10 days. So I'm telling you some ways of learning this because the same table comes to you in your medicine also and it's a little difficult, right? So when I say CKMB and troponin, both of them are rising roughly 2 to 4 hours. But CKMB, everywhere there are 4 alphabets. Na? So within 4 days, it's going to fall off. 2 to 4 hours may start hua, 2 to 4 days may gone. Troponin goes till T10. Troponin goes till 10 days.
Question 21. Which of the following is most abundant glycoprotein in basement membranes? Here are the options. A. Fibronectin. B. Laminin. C. Integrin. D. Syndecan. And the correct answer is option B. Laminin. Here's the explanation.
Let's move on to this basement membrane that I was teaching you about, glomerular basement membrane, and be it any basement membrane of the body. I have always told you that any basement membrane present anywhere in the body. So we had learned basement is kind of a floor. So which collagen did we study for it? We had studied collagen type 4. We had studied collagen 4. So which collagen is basement membrane made up of? Collagen type 4. So basement is a floor, floor is 4. Students often get confused in this question. Listen to the 2 questions that I'm going to tell you. Question number 1, if I ask you which is the most common collagen present in the basement membrane, what will your answer be? Collagen 4. But if I ask you which is the most common protein present in the basement membrane, and your protein answer is laminin. So laminin is the most important protein in the basement membrane.
Question 22. Which of the following disease has X-linked recessive pattern of inheritance? Here are the options. A. Hurler syndrome. B. Thalassemia. C. Hereditary spherocytosis. D. G6PD deficiency. And the correct answer is option D, G6PD deficiency. Here's the explanation.
G6PD deficiency. So what do you have to know over here? When I'm dealing with G6PD deficiency, I have already taught you some things. G6PD deficiency has an inheritance which is X-linked recessive. And whenever I say X-linked recessive, which is the gender which is more commonly affected, boys are more commonly affected. This we studied in our genetics chapter, hai na? So G6PD deficiency. So the name is only telling me the patient is going to be deficient in G6PD.
Question 23. Virchow's triad includes all except? Here are the options. A. Endothelial injury. B. Stasis of blood flow. C. Hypercoagulability. D. Platelet thrombus. And the correct answer is option D, platelet thrombus. Here's the explanation.
The famous Virchow's triad. Now all of you can tell me, and I know you are aware that Virchow's triad is a very famous triad that you study for thrombosis, right? Thrombosis, clot formation. So can you all recall for me that what is the classical triad that you have for Virchow's? Virchow triad, to kya hai the classical triad? Please remember the first and the most important, which is a question. The blood vessel gets damaged. There is endothelial injury that happens. That is point number 1. Point number 2, either the blood flow is very, very slow, means there is stasis, or the blood flow is very, very turbulent. So turbulent blood flow. So either there is very, very slow blood flow or very fast, so very turbulent blood flow. That's the second contribution. The third is there could be a state of hypercoagulability. Hypercoagulation. Hypercoagulability could be the next thing. So basically, Virchow's triad says that when all these three things or a combination of these three things occur, that is when a patient is going to have a clot or a thrombus formation. So remember, there is most important endothelial injury. Either the blood supply is very, very slow or very, very fast, and hypercoagulability. So who gave you this triad? Sir Rudolf Virchow gave us this triad. These are all his contributions.
Question 24. Which of the following is not a component of Jones criteria for diagnosing acute rheumatic fever? Here are the options. A. Pancarditis. B. Migratory polyarthritis. C. Erythema nodosum. D. Sydenham chorea. And the correct answer is option C, erythema nodosum. Here's the explanation.
There is something called a criteria, because rheumatic heart disease is just not about the heart only. There is something called a criteria in which you will have a major criteria, you will have a minor criteria, and you will have some supporting evidence. Major criteria, minor criteria, and supporting evidence. Let's start. Major criteria has, what is the name? Revised Jones criteria. So I've kept a mnemonic. Major criteria ka mnemonic is going to be Jones criteria only. So how simple? Jones criteria is the mnemonic, out of which JO tells me that there is joint involvement. When I say joint involvement, means there is migratory polyarthritis, and this is one of the early manifestations that we see. Migratory polyarthritis is going to be one of the earliest manifestations that we note. Next, N for nodules. There are subcutaneous nodules, and these subcutaneous nodules are usually painless. Coming to E, there is a skin problem. There is erythema marginatum. There is erythema marginatum. S stands for chorea. Which chorea? Sydenham's chorea, and it's come so in the end. See, it's come so lower down in our mnemonic, right? So this is one of our late criterias. Chorea, jerky movements, that's going to be one of our late, our late manifestations. Which was the early manifestation? The one that came in the beginning was early, and the one that's coming in the end is going to be late. And what is carditis? What is C? C obviously is carditis, but tell me something. Is this only a case of endocarditis? Like the heading of this topic was endocarditis, but is it only endocarditis? Now tell me. Aschoff bodies were seen only in the one place? No, Aschoff bodies were seen everywhere. Pericardium, myocardium, endocardium. So this happens to be a pancarditis. This happens to be a pancarditis, and for that matter, we've studied something else. Pancarditis means the pericardium has some kind of pericarditis. What was that pericarditis? Bread and butter. Remember, there was bread and butter pericarditis that I had explained to you that happens in rheumatic heart disease. And also I told you that Aschoff bodies are seen in how many layers of the heart? They are seen in all layers of the heart. This is an overall heart involvement, just not an endocarditis. Remember this word. Rheumatic heart disease is a pancarditis. That is your Jones criteria. JO for joints, N for nodules, E for erythema marginatum. Then we have Sydenham's chorea, and C for carditis, pancarditis.
Question 25. True for von Willebrand disease? Here are the options. A. Normal partial thromboplastin time. B. Decreased platelets. C. Normal prothrombin time. D. Normal bleeding time. And the correct answer is option C, normal prothrombin time. Here's the explanation.
When I'm talking about a von Willebrand disease, now this is the function of the von Willebrand factor that I told you. But is there another function of the von Willebrand factor that you guys already know? Do you already know from the beginning of the chapter that von Willebrand factor binds with something called GP1B9 in a process called platelet adhesion? So what did you analyze? Von Willebrand factor is doing so much of work. One way it is managing my platelets, one way it is managing my clotting factor. It's doing a dual work. Again, one way it is managing my platelet, one way it is managing my clotting factor. So now tell me guys, when von Willebrand factor becomes deficient or absent or any problem in von Willebrand factor, Will your platelets have a problem? Yes, you will say there will be a platelet adhesion defect. There will be a platelet adhesion defect because there is no one to bind to GP1B9. This means the bleeding time of this person will be elevated because there is a platelet problem. At the same time, there is going to be a factor VIII defect also. Clotting factor. Factor VIII is what pathway? Intrinsic pathway. This means the APTT of the patient is also going to be elevated. So now in the exam, when you get a scenario, the patient's bleeding time is elevated, matlab kuch platelet problem hai. Prothrombin time is normal and APTT is also elevated, means there is some intrinsic pathway factor VIII problem. That is the classical profile of von Willebrand's disease that you will sort out. So one question might be coming to your mind. Is this going to present clinically as a platelet problem or a clotting factor problem? Because I told you that platelet problems are going to result in superficial bleeds, and von Willebrand factors or all these factor VIII wala problems, they present as deep tissue bleeds. So von Willebrand is a both dual problem, platelet also, factor problem also. So superficial bleed hoga, deep tissue bleed hoga. So please remember, clinically presents more commonly as platelet bleeds, means clinically more commonly it has superficial bleeds. So you will come across a patient who's coming to you with petechiae, purpura, mucosal bleeds. Those kind of things would be mentioned clinically more. But yeah, it can show you a combo because you can see the combination of platelet and the clotting factor problem happening.
Subscribe and press the bell icon so you never miss an update from PrepLadder.